Right, so I want to welcome everybody back to the Ham Fellowship virtual debates. We want to apologize for the technical difficulty, but we are recording this, so hopefully others will be able to watch this at a later time. So first of all, I really want to thank the faculty and also the fellows for joining. I know things are returning back to being pretty busy for fellows, also the end of the year, so I know it's been tough for everybody to still stay committed to this. I think still been a great educational platform for others to share their thoughts and pearls across the country. So we are led by Dr. Osterman today from Philadelphia Hand Center. So this has been a little bit different now. He does have a home team that he's going to be moderating from Philadelphia Hand Center. So hopefully Lee will be a little bit impartial throughout the debating process. And it'll be Philadelphia Hand Center going against the University of Cincinnati, and also the Mayo Clinic will be joining as well. And the debate, I'm going to have Dr. Osterman go over more details, but the topic is PIP joint arthritis, looking at arthrodesis versus silicone versus resurfacing arthroplasty. And looking forward to another great debate and learning from everybody. So from there, I'm going to pass it off to Dr. Osterman. Thank you.
Thanks, Jerry, and welcome everybody. Let me see if my screen comes up. And is the screen showing all right?
Yes.
Yep.
Good. So welcome to the PIP arthritis debate between arthrodesis, silastic, and pyrocarbon. We have the three tag teams that Jerry mentioned. With their respective champions and their tag team fellows. We should remember the proximal or phalangeal joint is really the functional locus of the finger. 85% of digital range of motion occurs there. And when you look at satisfaction outcomes, the PIP is a major determinant of that functional and satisfaction outcome. The problem is the PIP is a bad actor. In fact, when you have a contracture of it, it starts to misbehave. And the most trivial injury, let alone arthritis, leads to stiffness and instability. PIP, osteoarthritis, inflammatory arthritis, and traumatic arthritis are the third most common site of arthritis in the hand after the thumb and DIP joint, and often are accompanied with significant pain and functional impairment in terms of motion. As we all know, when you have an arthritic joint, you have two simple choices, arthroplasty or fusion. And one could argue we shouldn't replace the PIP joint at all because PIP joint fusions are usually successful, one operation and good pain relief. But patients prefer motion when given a choice. Also, one has to think about the Quadrature Effect that occurs particularly with the three elder fingers. If you fuse the finger out, you inhibit not only the motion of that finger, but the adjacent fingers as we see here. Silastic has been around since the 60s, and it is really not a true replacement joint, but more a filler that's supported by the soft tissues. Been the benchmark, at least for arthroplasty, for a number of years. We know that in this follow-up at 5 years that it provides good pain relief, preserves a functional arc of motion, and doesn't necessarily, however, increase range of motion. Our illustrious Peter Stern, who's on the other side of this debate, came up and showed, at least in his series, excellent long-term outcomes. But all prostheses require careful soft tissue balancing, anatomical implant alignment, meticulous tendon handling, precise carpentry, and they require therapy, which fusion does not. And they have their problems: bone resorption, implant subsidence, fracture, stiffness, malrotation, revision. And we can say, however, that we do not in the fingers see silicone synovitis. And that's led us to think about more anatomic joints and other materials, such as pyrocarbon. Pyrocarbon is a synthetic material shown here, and one has a much more anatomically designed joint for surface replacement arthroplasty. And certainly in the laboratory model, it's a more physiologic design. It does have increased stability to laterally directed stress. but the outcomes are similar to previous metallic implants which have been there. There's been controversy in what pain relief they provide, and there have been squeaking described as well as other issues. And so tonight the ball is in your court. For the fusers, Peter Stern, what do you do about the quadriga? What's your favorite technique of fusion? What's non-union failure and how do you salvage it? What's your implant removal rate? And how about the neglected DIP joint distal to your fusion? For the replacers, I want to know what their favorite approach is. Do they do the dorsal extensor split or the chamet, or do they do the volar approach? What do they do about collateral ligament stability? What do they do about the index finger, which has a lot of lateral force, and what are their complications? Once we've heard a debate, I'll present a couple of cases from which they can add their 2 cents. So take it away. We'll start off with Peter and Ramiz on basically fusions.
All right, I'll just share my screen here and we'll get started. All right, everyone can see all right? Can everyone see and hear everything okay?
Yes.
Great.
Yeah, thank you.
Starting with arthritis, my name is Ramiz. I'm the fellow with Team Cincinnati here. So a common presentation, patient with significant arthritis of the PIP joints. This is going to be the starting point for all 3 of our teams today. So I think the central question to start with, and this is the same one we'll end with, is essentially, would you rather be one and done, end up with straight pain-free fingers, or chase a little bit of motion and maybe end up like this? We've reviewed already with Dr. Osterman arthroplasty options with silicone and resurfacing and the soft tissue balancing that they require to perform correctly in a patient. So we begin with a 67-year-old woman, rheumatoid arthritis, significant PIP arthritis, and this patient preoperatively, x-rays are as shown. They undergo PIP arthroplasty with Swanson silicone implants, and postoperatively, they're doing great. They're happy. This immediately post-op, they can start moving, and they're happy at their first 2 or 3 post-op visits. However, over time, as we know, this can happen. That's not a good day. Implant fracture is a common complication that may occur over time, and we know that the long-term longevity of these implants can be quite low, which we'll get into later on. Another problem that we know can happen, this is another complication everyone's trying to avoid with osteolysis around these Swanson implants or any kind of implant, really. And of course, the dreaded infection. The more soft tissue handling there is, the more risk there is, especially if there's an implant now in the site of an infection. So getting into some of the data, we know from work by Dr. Stern and others a few years ago that the long-term results of PIP arthroplasty with silicone at a 10-year follow-up, there was a good survival rate of the implant with some pain relief, no improvement in range of motion, but most of the implants over time fracture to deform by 10 years. So we get to pyrocarbon. Seemed like a great option, slam dunk, lots of high fives on the day of the surgery, finger is straight, it's moving, and hopefully not the same complications of silicone arthroplasty. But don't believe everything you hear. We certainly have no shortage of complications with pyrocarbon implants. We can see periprosthetic fracture and even fracture of the implant themselves. This patient had 2 implants, both of which had these devastating complications down the road. So maybe this one will work. Try another arthroplasty. Nope. We can also have dislocation along with fracture of the implant in these implants. So these patients, what do they end up with? They still ended up with the fusion at the end. So it does beg the question, why not just start with the surgery that a lot of these patients may end up with anyway? And let's not forget, make sure your volume is up, everyone.
Okay, go ahead.
This is certainly not something any patient wants to end up with on a day-to-day basis. So looking at pyrocarbon outcomes, the group at the Mayo a couple of years ago, large case series with a 6-year follow-up, 1 in 5 had to be revised within 5 years, and 1 in 3 underwent more than one procedure. Out of the Brigham, 20 years ago now, 29 implant series, midterm follow-up at 6 years with a quarter of the patients requiring revisions, and 14% as early as 4.5 years needed revision after this surgery. So let's stick to the facts. Great paper out of the group at Mayo comparing directly arthroplasty with arthrodesis. Both had good pain relief. Both regained strength after surgery. Of course, in the arthroplasty group, there was some preserved motion, where there was loss of motion in the arthrodesis group. But before we jump teams just yet, we need to look closely at the results. 114% complication rate in the arthroplasty group, compared to just a 21% in the arthrodesis group. So we know there are more complications, but we're also seeing from this paper faster complications. Patients who had arthroplasty done very quickly began having complications compared to those in the arthrodesis group. So we have more complications, worse, faster complications, and the complications that happened were quite worse. We can see arthroplasty versus arthrodesis, long list of complications. What I want to point out, though, is this table, focusing on radiographic abnormalities. Just simply the table without even reading the numbers, I think really gives a good impression. There are numbers only for the arthroplasty group. The arthrodesis group, there isn't even an opportunity for most of these complications. Really, all that the problem that they're focused on is non-union. There was only one patient in their series that had a non-union. All of these other complications happen only in the arthroplasty group. 25% in their series, even if you, in this series, looking at revisions, arthroplasty. So if there's a set of patients that failed the first time, what could you do? You could do a revision. A quarter of them will fail. And even in the patients whose revisions lasted, arc of motion was only about 39 degrees. And in the pyrocarbon group, only 18 degrees. So going through 2, possibly 3 surgeries to end up with a ratio between 20 or at best 40 seems like a bit of a stretch compared to a one and done approach. Arthrodesis, multiple techniques exist: K-wires, tension bands, screws, plates, or even compression X-fix. So I think the bottom line, looking at the literature, we know that arthrodesis works. There's good, reliable pain relief. Overall function of the hand is similar to patients who've had arthroplasty, despite motion of that one joint and that one finger. But it has 1/5 the complication rate. We know it's even good enough for a horse to walk on. So our preferred technique in Cincinnati with Dr. Stern, tension band arthrodesis with a dorsal approach. So to conclude, if you like this kind of outcome, certainly, by all means, one can consider arthroplasty. But if someone wants to live their life, fuse away. So thank you for your time. I think even here the masters might agree, fusion is the way to go. Thank you all.
Thank you, Ramit. I would only add that you didn't have any of those papers have a patient satisfaction survey. Patients often, despite the complications, are often still happier with the motion. And lastly, you have no quadriga questions. How do you get around that? And we'll ask that at the end of the discussion. Let's move on to Joe, Team Philly, to talk about silastic arthroplasty.
All right, can everyone see my screen okay?
Yes.
Very good. So I'm Joseph Tofty, and thanks to my mentor, Dr. Culp, we're from the Philadelphia Hand and Shoulder Center. And our goal tonight is to convince you that you should replace your patient's PIP joints with silicone with a few caveats. So as Ramiz has given us an idea of, there's a lot of literature out there, and there's a lot of studies that I would say compare apples to oranges. There's mixed cohorts, mixed modes of arthroplasty, mixed indications, which predictably leads to mixed outcomes. But I think if you go through the literature with a critical eye, you'll see that there are consistently solid outcomes for silastic PIP arthroplasty when they're performed for the right indications. So as we've talked about already, there's a lot of options out there. There's making your little joint look like a big joint. There's using a cushion and trying to interpose something. And then there's making your PIP joint as stiff as a board. If I were a contemporary arthroplasty surgeon looking at the PIP joint, I might think that it bore a striking resemblance to another large joint with a compelling arthroplasty track record somewhere else in the body. And I might even try to impact plastic and metal into this joint in hopes of making it move as well as it did when it started. And I might think this was a good idea, but I'm hopefully able to convince you that this is not the way to go. Because pyrolytic carbon, metal, and plastic have historically had very high secondary procedure and revision rates, 10 to 58% in multiple studies that you can see on the right here. 76 out of 294 required reoperation in this study from Mayo. That's 1.6 operations per PIP joint, with extensor dysfunction, loosening, collateral ligament failures, and contractures all being part of the problem. You might start to think that the only thing looser than the indications is their implants. Fusion also is not totally benign, and in a series of 290 tension band arthrodeses, there's almost a 10% rate of hardware removal and an appreciable rate of non-union and pseudoarthrosis. And the biomechanical implications of fusing the PIP joint are not insignificant. As Dr. Osterman has reminded us, quadriga is a consideration, and PIP arthrodesis leads to trade-off in precision pinch dexterity and pinch aperture. Well, does pinch aperture matter, you might ask? Let's just say with a fused PIP joint, that fish story just got a lot more believable, Dr. Stern. So silicone. I think silicone is an elegant solution that befits a hand surgeon. It's made from a polymer made from the element silicon and pioneered in the 1960s by Dr. Swanson, who also did some of the first biocompatibility studies in bone. And it's enjoyed a great track record in medicine as both a functional and aesthetic implant, as many of these satisfied patients below will attest. So what's it good for? Well, it's good for pain relief from osteoarthritis and post-traumatic arthritis, and it's good for maintaining a functional arc of motion. Notice I did not say improving. What's it not good for? Well, severe pre-existing deformities, stiff joints, because you can really only make small gains in motion, if that. The index, even the long finger, have been controversial, and inflammatory arthritis or the ligaments may be incompetent. And if you have very high demand patients, they can work through an arthroplasty more quickly than a low demand patient. But the outcomes are good, and Dr. Stern's paper is not the only one out there, I should point out. With follow-up up to 20 years, the survivorship, and that means non-reoperation rate, is good. The motion is similar to preoperative, so a stiff finger is still a stiff finger, but the reoperation rate is low for silastic in isolation, and it's a solid outcome. The index finger, at least one study has demonstrated increased rates of instability in the index and the long fingers compared to the ring and small. But recent literature suggests that this is not always the case. In 47 consecutive silastic index finger arthroplasties at 5 years follow-up, the motion was good, instability rates and reoperations were low. So the bottom line is that yes, the risk of instability increases in radial digits. But if you and your patient, preferably a low demand patient, can tolerate a little painless ulnar drift, index and long can usually be replaced. And why should we do this? Well, because patients prefer it. Here's a 200 patient survey looking at patient preferences for PIP joint surgery, and avoidance of joint stiffness is the #1 consideration among all other factors. What approach? Well, the outcomes are mixed. Volar approach in one study leads to better quick dash and PIP flexion. In another study, there's no statistical difference between volar and dorsal approach among any factor. We talked a little bit about implant breakage. Well, yes, they may break, but it's important to note that with a robust fibrous reaction created, you have a shock absorber built into the joint. So even if there is some deformity, patients often have painless implant breakage and do not need a revision. And if they do, it's still an option. You can revise silicone to silicone or other arthroplasties, and the results are not bad. The range of motion can improve for a stiff joint, satisfaction is reasonable, and pain levels are low, and importantly, no silicone synovitis is observed. And if it does come to a fusion, you can still fuse a finger that had an arthroplasty. The complication rates are higher, at least in some studies, with a high non-union rate, some requiring revision arthrodesis, but across other studies, the union rate is more predictable. So in summary, if PIP arthritis is like going to your mechanic with a flat tire, surface replacing arthroplasty is you're going to pay 1.6 times the cost of your silastic in terms of complications, and you're going to have to come back in a week for another tire change. And if you leave with a fusion, you're leaving with a wheel that doesn't roll anymore, and you'll be going down the highway like this guy. Most importantly, why should we choose silastic? Well, because Dr. Stern and Dr. Rizzo both independently recommended it. Dr. Stern states here that the silicone implant arthroplasty is his treatment of choice. And Dr. Rizzo states that for PIP osteoarthritis, silicone remains the gold standard. I think those are pretty compelling endorsements, and I'll leave you with that. Thank you.
You need to unmute.
All right. Thank you. First of all, I wanted to thank my mentor, Dr. Rizzo, for his help and guidance with this talk and throughout the year. I also wanted to thank Dr. Wang, Hammert, and Osterman for inviting us to participate in this forum. My charge is to advocate for the correct choice, the SRA or pyrocarbon arthroplasty. So I wanted to start by considering the biomechanics of the PIP joint and PIP arthrodesis. So in a study by Hume et al., they characterized the functional PIP range of motion during typical ADLs as 60 degrees. They importantly also described specific positions of the PIP joint during activities, and they noted an average of 39 degrees in grasp and 78 degrees in grip. Both of these are limitations in arthrodesis as outlined by Joseph. Woodworth et al. Simulated PIP arthrodesis in normal healthy patients and reported that 9 out of 13 ADLs were rated as statistically more significant. Keep in mind, these were people that had normal adjacent joints and were able to compensate accordingly. So they were only able to conclude in the study that those without other hand impairments may adapt during lower demand tasks. Dumelian et al. Evaluated the kinematics, as Joseph had pointed out, and really noticed a significant change in that grip aperture, which can contribute to decreased function, especially with grasping larger objects. They further looked at the precision pinch in these patients and noted a significant variation in that at the DIP and MP joints, as well as through the thumb, there wasn't precision in terms of motion during normal functional activities. Kemper et al. Reevaluated the ideal angulation of PIP arthrodesis and found that patients were unsatisfied with the previously described and accepted ideal positioning, being 40, 45 degrees, 50, and 55 in digits 2 through 5. So Stenson et al. Also reviewed the management of arthrodesis and arthroplasty complications and pointed out that arthrodesis is not without complication. With an up to 21% non-union rate, there's also infections, revision surgery. So while potentially more reliable in terms of outcome, arthrodesis is certainly not the ideal option from a functional or patient satisfaction standpoint. Moving on to silicone implant arthroplasty. Fowler and Nicole evaluated the biomechanical forces across the PIP joint and found a significant variation in loading at the radial and ulnar joint surfaces during different tasks. So you see the radial here, ulnar here. During jar turning and tap turning, there's significant variance. So I would argue in PIP arthroplasty, we must consider the effects of asymmetric loading at the joint surface and implant interface and how that affects stability, fracture, and survivability. Minamikawa evaluated the lateral stability of silicone implants versus SRA, silicone in this table, SRA over here, and found significantly worse coronal plane stability in the silicone arthroplasty. More worrisome, there's significant angulation and deformity with as little as 250 grams of force. Importantly, all of these arthroplasties were done under the ideal circumstances. Non-arthritic PIP joints with no bony resorption, allowing full preservation of the collateral ligaments, which isn't always possible with the silicone arthroplasty. As kind of a baseline, you look back at this study by Smeby et al. In the tetraplegia literature that defined the amount of force required in simple ADLs. And they noted that all of them, except using a remote, required more than 250 grams of force. And while that may be acceptable during COVID, most of us want to use more than our remote in our daily lives. It is important to note that one of the most prominent studies advocating for silicone arthroplasty, when you closely examine the Likert scale, it showed that patients may not have been as enthralled by their functional improvements or finger appearance postoperatively. I think part of that is in part due to the statistically significant increase in coronal plane deviation seen in these patients. Further, in the study, they also didn't test or evaluate the coronal plane instability these patients had, which I would argue is a significant limitation of the study. So PIP, osteoarthritis, they're all doomed. Why should I operate at all? Let's go back to the inception of the SRA, or metal on plastic implant. This was specifically designed for more physiologic articulation, insertion with minimal bony excision, preservation of the collaterals, and importantly, more coronal plane instability. Of note, it was specifically designed to be cemented in as well. In one of the largest case series, Murray et al. Described their experience with SRA and reported comparable survivorship to the silicone arthroplasty, improved visual analog pain scores, preserved motion. You'll note here, patients with osteoarthritis fared significantly better than those with rheumatoid arthritis. Complications were mainly soft tissue related, so patient selection is important. And again, additional procedures are mainly soft tissue associated, which again points to patient selection. Jennings and Livingstone also described their experience with the SRA and found excellent survivorship and a much higher success rate in those that had cemented implants. I would argue that the PIP literature argues that pyrocarbon PIP arthroplasty is also a viable alternative to in the right patient. Wagner et al. Reported on their experience with pyrocarbon PIP arthroplasty at an average follow-up of 6 years. Their study also included a significant portion of what you would deem as difficult cases, those with inflammatory arthritis, those with pre-op instability, and those requiring bone grafting intraoperatively. You'll note they reported retained grip strength, motion, and improved pain scores. They also noted that there was excellent 10 and 5-year survival free of revision in all comers, 79% and 77%. And specifically in those with a narrow indication of osteoarthritis, a survivorship of 87 and 83% at 5 and 10 years. Taggell and colleagues reported preserved motion, strength, and visual analog pain scores that were improved with 96% survivorship and a low reoperation rate. The Reddington group found similar success with the pyrocarbon PIP arthroplasty, 97 fingers, 5-year follow-up, 85% at 5 years. Pritch and Risso, as alluded to earlier, reviewed their experience with reoperations in the non-constrained PIP arthroplasty. As you notice, again, these are predominantly soft tissue related, making it important to consider your indications for this implant. Going back to the only prospective randomized controlled study, non-cemented components were placed. The revision rates of SRA and pyrocarbon may also have been falsely elevated by revisions for asymptomatic loosening. And I would argue in this study, the subgroups are not comparable, as the pyrocarbon and SRA implants were disproportionately placed into patients with multiple joints in the same hand. That increased the demand on that implant and significantly confounded the DASH scores the patient had. When you read the addendum for that study, 21% of the silicone implants went into a hand with another implant, as opposed to 61 of the pyrocarbon and 65 in the SRA. 17% of the pyrocarbon and 35% of the SRA went into a hand with 3 implants in it. So the DASH score, which was the only significant finding, was not comparable. So I'd argue that arthrodesis is non-anatomic, it's functionally limiting, and it may not be as reliable as we think. The silicone arthroplasty is non-anatomic. There's issues with coronal plane instability and limited patient satisfaction. The SRA and pyrocarbon implants are anatomic. They're much more durable. They have fewer issues with coronal plane stability in the right patient. Yes, they are more technically challenging procedures and have narrow indications, but let me put it this way. If I have significant miles yet to travel, I choose an aerodynamic, fluid, state-of-the-art engineered machine rather than other options. Thank you.
Thank you, Dana. Well, I must say that each of the champions argued elegantly for their positions, and it does reflect the state of the art that we're dealing with. Since we have the experts here, let me see if I can get some answers to my questions. Peter,
Yes.
what do you do to avoid the quadrature effect? Do you shorten, let's say, the ring finger if you're fusing that?
Sure, but I don't think, I would not argue that the amount of shortening that occurs with an arthrodesis is enough to cause the quadrature effect. Quadrature effect generally occurs if you over lengthen the profundus tendon, kind of neutralizing the middle ring and small tendons. So I don't think quadrature effect is the problem. The problem is that the joint does not move. So I think that quadrature effect is, to use an old term, poppycock.
If you hold, I will tell you, if you hold your ring finger out extended, Peter, and you try to bend your other two fingers, they don't flex fully into the palm. Call it quadrature, call it
No,
tethering.
Lee, you're still bending your MCP and PIP and DIP joints. Give me a break, my friend.
And lastly, one of the problems with fusion of the PIP joint often is the DIP joint is not a normal joint. So it tends to be things so that the motion that we lose is really becomes a metacarpal phalangeal joint finger. You do anything about the DIP joint, for example, in a traumatic PIP fusion?
Yes, I think that point is much more relevant, and I believe that any procedure that you do on the PIP joint, be it silicone surface replacement or arthrodesis, can end up with exacerbating DIP range of motion. I think postoperatively, it's extremely important during the rehab period that the patient and the therapist work to maintain DIP joint motion. No question that it's an issue. It's an overlooked joint.
Randy, what do you do with an index finger that's arthritic? Are you following the fusion group, or are you going to go with the replacement?
Well, I have had three approaches to this. Typically, I was doing fusion for years. And based on some work by Peter Stern, I'm now looking, well, then I thought maybe the pyrocarbon was the answer, that if the collateral ligament, radial collateral was intact, the pyrocarbon was the answer. But I did not find that to be the case so far. I have been looking at index PIP osteoarthritis with silastic implants with radial collateral reconstructions using internal brace. But I only have 3 cases so far, so it's too early. But they got about 40 to 60 degrees of motion and they're stable, but we need much more follow-up.
I think, as you know, I share that sentiment. How about what approach do you use on an osteoarthritic ring finger, 20 to 60 degrees of motion, relatively stable, just stiff and arthritic? Are you going to do a volar approach, or do you like the dorsal approach, and which dorsal approach?
I like the volar approach for most of mine. I think that they get better extension because you're not going through the extensor mechanism. I think it's easier to make your cuts when you're using a volar approach. And I know that Peter's done a look at a paper where the results are about the same, but I think it's more difficult to make your cuts from a dorsal approach. I've done 2 dorsal approaches. I've split the tendon longitudinally. I've done a Chamet, and I've found really no differences in using either one.
Is the fact if a joint has a boutonniere versus, let's say, it's just a stiff osteoarthritic joint, I tend to use the dorsal approach if I have a boutonniere that I'm replacing, and volar for the uninvolved extensor mechanism. Does that influence you at all, or am I just fooling myself?
No, I think that's true, because at least if it's boutonniere, at least you can do something to tighten up the extensor mechanism. Maybe postoperatively do a short arc therapy protocol instead of the usual protocol to protect your tightening of that tendon. Fixed boutonnieres is a whole other ball game.
Well, fixed is different, I agree, but soft boutonnieres. Marco.
Yes.
One pundit once said that the surface replacement arthroplasty is the best joint to use if you have a normal joint. If you don't have a normal joint, it's not necessarily the method of choice. I mean, you've championed both silastic and pyrocarbon. Do you pick and choose who gets what, or is it patient says, I want a Ferrari that costs more money and I like the anatomic approach, as Dana suggested? Or do you say, who hasn't seen a silastic, who hasn't seen a pyro, I'll pick whatever. How do you choose?
That's a great question. I guess, you know, a lot of it depends on the patient preference. I think if it were up to me, I'd fuse them all, you know, but patients want motion, like you said, you know, and by and large, then it becomes a nuanced discussion. You know, it depends on their stability. I wouldn't consider a non-silastic implant in inflammatory arthritis. In addition, if they have a lot of angular deformity on X-ray and they're, you know, they're showing laxity on the radiocollateral ligament, and if there's erosions in the bone that make it challenging with respect to the bone cuts, I'll lean hard for silastic. Or something that provides some better coronal plane stability if I can get it, like an SR implant. So it becomes a very layered discussion with these patients and trying to give them the pros and cons, at least in my opinion, of what each are. But I've become very fundamentally frank about the motion thing and the motion aspect of this. This is a pain relieving procedure, not a motion improving procedure. So that's really cut down on a lot of those reoperation rates. You know, those reoperation rates that get criticized in these articles are largely our own fault. You know, we're trying to get patients better motion and we keep going back for surgery and trying to improve that, but we have to really respect the fact, like you said, Lee, that this is it's a bad actor, this joint. You give it one try and you say, look, we're going to try to get some motion, but in reality, you know, if you come back stiff, there's no science to say that we're going to be able to make that better. Now, to go back to your question about, you know, how do you decide? It largely becomes an issue of how much stability do they have in that coronal plane, and am I going to be looking at one of these silastic implants that have coronal plane instability versus something that might generate different other complications, you know, such as the SR or the pyrocarbon. And I don't have a formula that is hard and fast. It becomes an issue with just trying to determine with the patient what their personal preferences are. I think silastic does remain the gold standard, though. I will say that.
Ramiz was pointed out in his discussion that some joints will play the violin like a squeaky wheel. If you see squeaking in a surface replacement joint, do you think that's been done away with in the pyrocarbon group pretty much, or is it something to worry about, or is it just a tell when he's playing poker?
Yeah, it's a bit of a party trick. It's not painful, you know, so it's something to me that you know, as long as the patient's aware that it may happen, and I really believe a lot of it is because you can't make it squeak with passive motion. It has to be active. So there has to be a translational component to it when they move. But I don't see it with the SR. I only see it with the pyrocarbon. So by and large, other than anecdotally saying you may be squeaking afterwards, now some people can be annoyed, like Peter showed, you know, and he brought it to my attention initially when he first published on it. But I've had several squeakers, and by and large, thankfully, I've been able to give them a heads up and say, this may happen, and they haven't been that disgruntled.
But does it imply increased wear because they're shear making the squeaking noise, or not?
I can't prove that. I can't prove that, Lee, and I'm not worried about it because pyrocarbon is a wonderful material. The only downside is you can't get any bony integration into the stem. It has very little wear, and it's inert, so it doesn't generate any debris that incites an inflammatory reaction like silicone will. And basically, its Achilles heel is that you can't get bony ingrowth, and it just functions like a spacer, unfortunately. The nice thing is it's easy to remove them. The downside is that the physics of it lead to some of these catastrophic loosenings that we see, like, you know, in Peter's article, you could see, and we all have them. If you do pyrocarbon, there's these loosenings that occur that are just ugly to look at. But if we had bony ingrowth, I think we might inherit different problems. But the reality is that beyond that, its elastic modulus is really good. It has very little wear characteristics, and it's biologically inert. So it's a good load sharing device. It just unfortunately gets loose in certain people. In some people, there's a happy balance between the bone loading and the implant. And in those patients, they do quite well for quite a while. It's just hard to know who that person's going to be.
Okay, well, let me show you a couple cases that are my problem children or questions, and I'll ask each of you to help me out. If I can share my screen here where whoops, where did my, sorry, trying to find my.
Lee, while you're doing that, I saw a question. How do you decide between an SRA and a pyrocarbon?
I can comment to that. And I will say this about the index finger, just as a caveat. You know, we looked at border digit outcomes versus non-border digit outcomes, and in arthroplasty, we really didn't notice a difference in outcomes. So I think that points to giving us more confidence that the index finger is worthy of an implant. Of course, I'm one of the co-authors on the damming study that looks at the fusion versus arthroplasty. But the reality is, as you said, Lee, people want motion. You know, it's hard. It's a tough sell. If you look at that study, only 14 were fusions and over 60 were arthroplasties, in a large part because patients don't want anything to do with the fusion. It's a tough sell. But I've actually gone away from the pyrocarbon total. I tried the pyrocarbon hemiarthroplasty in certain patients if the bone lends itself to it, because I think it's a pain relieving procedure that doesn't invite the catastrophic loosening. And by and large, for a primary arthroplasty, I really lean hard more towards the SR implant because I think it's a better implant and more durable.
Thank you, Marco. Is the screen up now for people to see?
No, I don't see it, Lee.
Okay, let me, I don't see my share screen here. Sorry.
Should be at the bottom of your screen somewhere, Lee. Is it on the bottom of your window somewhere?
That's what I'm looking for. I don't.
Bottom middle is a green arrow.
Yeah, I'm pressing Zoom and I'm.
Lee, can you describe the case?
Well, no, it's a young woman. I should be able to get it, Randy, but it's a young woman, nurse, small finger PIP joint, has a dislocation while walking her dog. Here comes share screen. And where's my talk?
There it is.
Is it up yet?
Yeah, it's up. It's up now.
Okay, so there you see the finger. Very limited motion at the PIP joint, 5 to 25. DIP joint involvement. A little bit of a boutonniere, as you can see, not really boutonniere, but enough. That's how she was treated initially for that pin. She had 9 months post that surgery and therapy for a while. Peter.
Yes, Lee.
What would you like to do with this? What are you going to tell this nurse?
So first of all, I don't think there's a boutonniere deformity.
No, not any longer. No, not any longer. That's what she started as. Had a closed reduction and pinning for 6 weeks.
Okay.
And then ended up with this.
Lee, was there any infection post-operatively?
Not that I didn't treat her initially, but the answer is no. In fact, initially, after she was unpinned, she had pretty decent motion by about 2 to 3 months post-therapy, and then it started getting worse and more painful.
Okay, well, again, this is, as Marco very eloquently said, this is a tough discussion. The small finger far and away is the biggest bugaboo in virtually any type of reconstructive hand surgery. She is more or less middle-aged, and I don't think she would go for an arthrodesis of the joint. I would assume that her terminal joint has some motion in it, although the distal phalanx looks a tiny bit, the DIP looks a tiny bit arthritic. So to cut to the quick, I probably would do an arthroplasty. I doubt that she would have an arc of motion of much more than 35 to 40 degrees. And I think over long term, the implant would fracture. And I do believe, and we've biopsied a number of silicone revisions, and they do get particulate synovitis. The encapsulated cocoon, if you will, if you remove it during the revision, send it to the pathologist, you'll see foreign body reaction with giant cells. So I would go with a silicone arthroplasty. I think a fusion of the PIP joint of the small finger is moderate. Oh, good for you, Lee. There's hope.
So she got to look at that.
Lee, I want to see it. Come on.
I'm telling you, look at that motion. I was very proud of this. That's why I brought this case. I resected enough. I think you can leave. You want to get the right size implant. You can't be double O's and O's. You have to usually be a 1, I think, to make sure you don't get overgrowth. But here she is at 1 year. I was walking on water and then sent her off on her way. See ya. She came back 3 years later. No pain, no new injury. But now her MCP joint has fallen away. It's back to that initial motion. Is absolutely no change on the x-ray. No infection, no pain. She just stiffened up. So now her x-ray looks almost like, see, this is 1 to 3 years, not really the early x-ray. But now she has that motion. So I guess the question is, why did she stiffen up at year 3 without any use? She was using it. She wasn't babying it. And what would you do now?
Are you asking me?
Yeah, you're still your case. I got 3 cases, 1 for each of you.
This is absolutely not an uncommon scenario. So they start off, at the 2 to 3 month interval, they're doing well. They've got pretty good motion. And I think if you serially look at both silicone and surface replacements, the range of motion deteriorates over time. I would not recommend any further surgery, despite the fact that she has significant limitation of motion. I just honestly do not think it's going to work long down the road. I'm sure you're going to show me a 30-year follow-up with 90 degrees of flexion, but it's going to be a different patient that you're showing me.
Do you think it's silicone synovitis that made
No,
her stiff?
definitely not. There's no evidence of silicone synovitis. It takes a long time for silicone synovitis in the PIP joint to develop, and you see endosteal scalloping. I see absolutely no evidence of that. I think that she has developed a significant capsular contracture, and I think to reoperate and potentially even do a flexor tenolysis is not going to leave her any better.
Well, I never wanted to say defeat, and Marco, I think, was very right on when he talked about the problems that most of the revisions in a lot of times are to try to regain more motion than you're probably ever going to get. But you have a patient, you don't have a best scientific evidence. And so, though we lost motion, she wanted to go for it. And so there's your tenolysis, Peter, done under wide awake anesthesia. The joint was solid, didn't open the joint, just did a tenolysis, as you can see. Here she is, oops, sorry. I don't know where her picture went, but suffice it to say, she did as an early result, and we're still 2 months down the road, end
Holy.
up with functional motion. Got it. I understand it's not going to work, but you do it because the patient wants to try. And I at least remember one where we did regain the baseline motion. So we'll see, but I agree with you. It's probably damned from beginning. All righty, this is for you, Randy. 62-year-old right hand dominant CEO and golfer, Dupuytren's contracture, right fifth finger. He's had 3 ops on this finger, including a skin graft and including a digit widget. He's got this finger. Oh, that's the woman. That's her post-op at a week, and I don't know where the next picture went. We don't need it, but there he is. He's got an MCP joint with good motion. The Dupes is more or less under control, except the PIP joint, which has had everything but has that fixation. He was given the following options. The joint's not arthritic, as you can see. Live with it. Amputate, he wouldn't go for, so replace or fuse. He's a golfer.
Well, I think the problem with replacements here is because the soft tissues around the replacement are not likely to be able to get him a return of motion that's going to be useful to play golf. I mean, I think what you're getting at is that, if this his left hand, his non-dominant hand?
Yes.
So, will he be able to grasp the golf club in the same manner because that's such an important part of your hand that you should do a replacement? But the problem with fusion is that your finger gets quite short when you fuse somebody who has Dupuytren's disease. And but I would probably, if do anything at all, I'd probably fuse it.
That's what we did, and we fused them a little straighter than you sometimes see recommended. I think the values of fusion are overrated. I tend to under angle per se. He did return to golf at about 2 months. Didn't say he had any loss of his thing, but I'm not sure how good a scratch golfer he is. Finally, Marco. Peter mentioned, and I mentioned the DIP joint, and I figure it gets neglected, so I thought I'd throw this one in. 54-year-old right-hand dominant,
take it for the first couple
second
days.
violinist in the orchestra.
It interferes with the fusion. Yeah.
And increasing stiffness in the DIP and finding it harder to play. So she's got pretty good PIP. She has osteoarthritis. Thumb isn't bad. No other joints bother her. These joints are basically stiff, and she can't. This is her left hand. She can't play like she has to keep her second seat in the orchestra.
Okay, well, this is tough. I mean, the fusion's certainly the gold standard here. We have had some limited experience with silicone DIP, but it hasn't been universally successful. I was at a British Hand Society meeting about 2 years ago, and there was a fellow from Pulvertaft Center who was talking about designing an implant specifically for the DIP, and he was looking into it, but I don't know that I've heard much more about that since.
There have been a couple almost Hemi replacements that have been suggested.
And that's what I think would be a reasonable choice. And if this patient really wanted to preserve motion, I would strongly consider a pyrocarbon hemiarthroplasty. It looks like, depending on what the surface of the base of the distal phalanx looks like, I think it would be a reasonable thing to try to do.
Well, I mean, those discussions were had, and the other discussion is, we talked about at the PIP joint, we really don't pick up motion. The question is at the DIP joint, do you? And we're running a series of what we did here. This is the motion you need to get to play the violin, just in case you're interested. And here she is. I forget what air she is. So you can see that she has DIP replacements of
that's
her
outstanding.
joints. And here it is, the little one we left. But this is a few years down the road follow-up. And surprisingly, she did get that amount of motion that she needed. And here she is. So this is the Sherazade of the DIP joints.
Oh, I have to applaud that. That's outstanding, Lee. That's a beautiful result.
So, I mean, I do think we have to think about the DIP joint as we proceed through. I won't take you through our whole concert.
Your point's so well taken regarding you know, the casualty of the DIP, regardless of whether you do fusion or arthroplasty. I mean, that DIP suffers from each of our procedures, and it's a double whammy because they lose motion at the PIP even with an arthroplasty, and they lose motion at the DIP as a result of our surgery at the PIP.
It's 9:06. I know we started about 5 minutes late, so I think we've used our hour. I think hopefully we raised the points about the PIP. I mean, I can't say anything but plaudits about the 3 presentations that were given. They were superb. I believed and was voting for each one after I heard it because they convinced me until I heard the next one. So I'm not sure I've left this meeting with the absolute certainty of what I'm going to do on any given joint, but I think it has left me with the fact that none of our solutions right now are as ideal as they are for large joints. And so there's lots of room for all the young fellows to think about researching and developing this for their patients. There are new materials coming out in ceramics and other things. And so maybe there is a better way to address the collateral ligaments, as Randy said, with stabilization techniques in addition to the prosthesis. And so I think you have to individualize. I think, you know, when you're early in practice, I would stay with fusions just because, you know, you want to save elbow replacements and PIP replacements for your latter career so you can hopefully outlive them or they'll outlive you. So thank you all. And again, thanks to Jerry and Warren who continue to set up these extremely fun debates where we really kind of hopefully get into the real depth of a subject. So thank you all.
Thank you.
Yeah,
Have a good
thank
night,
you.
everyone. Thanks.
Excellent discussions and great points for everybody. Dr. Osterman mentioned really no clear answers, but lots to think about for the fellows. It's really all the attendees, a lot of learning pros here. And really appreciate everybody for really supporting this throughout the last few months. Hopefully it's been a good platform for everybody. Stay tuned. We do have a debate next week, just based on kind of trying to avoid conflicts. And then from August on, it's going to be once a month. But really want to applaud the fellows again for an outstanding job. And Dr. Osterman, Dr. Stern, Dr. Culp, and Dr. Rizzo, just certainly great learning points for everybody. Lots to think about for the fellows moving forward and their careers in 3 weeks. You guys are going to be on your own. So just start taking notes. But no, have a good evening, everybody. Thank you for joining again.
Thanks, Jerry.
Thank you, guys. Have a good night, everyone.